to the Thyroid Stimulating Podcast. This podcast was created in partnership with the American Thyroid Association to discuss up-to-date diagnosis and management of a wide array of thyroid diseases. For today's episode, we are focusing on a very specific yet increasingly relevant topic: the thyroid immune-related adverse effects of immune checkpoint inhibitors, a groundbreaking class of drugs that have revolutionized cancer treatment but come with their own set of challenges. We'll explore the mechanisms of action of immune checkpoint inhibitors, then delve into the common thyroid-related adverse effects of these treatments can induce, and then finally discuss how these are diagnosed, managed, and monitored in clinical practice. Joining us today is Dr. Afreen Shariff, an associate professor of medicine at the Duke University School of Medicine, with expertise in endocrine diseases in cancer patients. Dr. Shariff completed her internal medicine training from East Carolina University's Brody School of Medicine and fellowship in endocrinology from Duke University School of Medicine. She is currently the director of the Duke Endo-Oncology Program and an associate director for the Cancer Therapy Toxicity Program at the Duke Center for Cancer Immunotherapy. Her clinical work and research are focused on high-value care for managing endocrine diseases in cancer patients, for which she has received the 2023 Innovator Award from the Association of Cancer Care Centers, and now serves on their board of trustees. Additionally, she is the host of a medical podcast series, Checkpoint Now, where she highlights shared decision-making between oncologists and subspecialists for management of checkpoint inhibitor toxicities. Thank you for joining us today.
Thank you for having me on the podcast today. It's such a delight to meet you and also record this podcast.
Okay, so I wanted to start off by quickly reviewing checkpoint inhibitors, a brief background about them, and how they've kind of changed the landscape of oncology.
Absolutely. Now, 2011 really marked a pivotal moment in oncology with the approval of ipilimumab, the first FDA-approved immune checkpoint inhibitor for non-resectable metastatic melanoma. Following suit in 2014, pembrolizumab, nivolumab really gained FDA approval for melanoma treatment. And since then, there has been a remarkable surge in FDA approvals exceeding 50-plus indications, with several more in the pipeline. Now, undoubtedly, this has revolutionized the approach of oncologists towards patient care. Presently, checkpoint inhibitors are being integrated into combination chemotherapy regimens for adjuvant, neoadjuvant, and early-stage cancers, really reflecting a significant shift in treatment paradigms. So in short, immune checkpoint inhibitors have really taken the market by storm and are here to stay.
So since they're here to stay, we've also noticed some significant side effects from these medications, right? So this podcast focuses on thyroid, so I kind of wanted to go over what are some of the common thyroid-related adverse effects associated with the use of these immunocheckpoint inhibitors.
Absolutely. The most common one that we encounter, seen in about 15% of patients, is immune-related thyroiditis, which sort of presents very similar to traditional thyroiditis, except I call it the cousin of the same family because the presentation and the phenotypic description of patients is a little different than what we see in traditional practice. What we end up seeing is more commonly in about 15% of patients thyroiditis, and less commonly Graves' disease, which is seen in less than 1% patients.
Do you guys ever see hypothyroidism?
We do, and it's quite common actually to see patients with hypothyroidism. In fact, when we talk about thyroiditis, we're talking about a movement in the patient's thyroid from being thyrotoxic to moving into what we call a hypothyroid state. The way I explain this in very simple terms is that the thyroid gland is a water balloon which is full of thyroid hormone. And when these immune checkpoint inhibitors really hit the thyroid gland, that balloon breaks up into pieces. And what happens initially and very abruptly after this immune-mediated adverse event or reverse reaction occurs in the thyroid is that you have a big surge or a big release of preformed thyroid hormone, which results in thyrotoxicosis or a hyperthyroid phase in patients. And most often, this phase converts into what we call a hypothyroid state. And I say that very clearly as a phase and a state because most often this is the trajectory of how patients proceed from being hyperthyroid to hypothyroid. And Some patients can also present directly with hypothyroidism because we haven't just had enough time or chance to review or look at their labs, and they transitioned very quickly from being hyperthyroid to hypothyroid.
So speaking of labs, is this the best way to monitor patients? Should they get labs frequently before they get started at the time of treatment? Or how often should we get labs for these patients?
Great question. The good news is that when patients are on active therapy, oncology guidelines actually recommend that patients get TFTs or thyroid function tests, including a TSH and a free T4, and also a total T4 done at every time they receive an infusion. And patients, when they're on immune checkpoint inhibitors, they can receive infusions every 3 weeks or 6 weeks, depending on the regimen, the dose, and the type of treatment or monotherapy versus combination. So the good news is they get labs done very frequently, and it's easier to detect these patients and catch them in which phase the patient is presenting in. Now, whether there is importance of getting TFTs pre-treatment before the first treatment is done, I would, as an endocrinologist and anecdotally based on the number of patients that I see with thyroid-related abnormalities, say that there is certainly a place and a space for getting TFTs well before the patient's treatment is being planned, because oftentimes they get the labs done on the day of the first treatment, which in patients who have pre-existing autoimmune conditions of the thyroid gland, or say exposure to iodine previously can have abnormal TFTs prior to them being initiated.
And speaking of TFTs, do you also recommend getting antibodies at any time for these patients, either prior or during treatment or after diagnosis of thyroiditis? When would you recommend that?
So it would be great to have that kind of information before patients get started on treatment. But what we've learned with observational studies is that antibodies, especially antimicrosomal antibodies, are present in about 30 to 40% patients and really not helpful in directing what kind of treatment or monitoring you would recommend for the patient. For example, if a patient had abnormal TFTs or normal TFTs with a positive antimicrosomal antibody prior to getting started on treatment, you would still not start the patient on any treatment. You would still monitor them. And these patients are anyways getting their TFTs checked every 3 to 6 weeks. So it really does not seem to change the way we would practice or do things differently. So as an educational, opportunity, yes, it would be great to check antibodies prior to them patients getting immune checkpoint inhibitors, because it perhaps adds more value to who is at a higher risk versus another one. But clinically, it really doesn't add up as far as what it would do to change intervention.
And so I'm also assuming that family history doesn't make a huge difference if autoimmune conditions run in the family. Do you monitor more frequently or you just monitor the same?
You would still monitor the same way. You would expect that these patients would develop immune-mediated thyroid disease or immune-related thyroiditis a bit sooner than, say, another patient who didn't have a family history. For example, the median time to develop the thyrotoxic phase in patients is about 5 weeks, and to develop hypothyroidism in these patients is about 10 weeks. And if someone had a predisposing condition, other autoimmune conditions, or a family history perhaps of thyroid disease, those patients tend to develop thyroiditis sooner than the typical expected median time for development.
So they develop symptoms sooner, but are they more likely to get these complications?
Well, the general sense is that we have observational studies to support that the patients who have pre-existing conditions, autoimmune conditions, have a higher risk of developing immune-related adverse events and even worsening immune-related adverse events. For example, if someone already has thyroiditis and is on replacement thyroid, hormone, the dose may require to be adjusted after they get exposed to tell us that, yes, there are some additional changes that are happening in progression of diseases despite them having pre-existing conditions.
So with that, I know we've been talking a lot about diagnosing and monitoring. As far as like treatment goes, what would you recommend for treatment? I know it's slightly different from the thyroiditis versus the Graves' hyperthyroidism. Can you kind of talk about those two?
Absolutely. So when we're talking about thyroiditis, so let's pick up first the thyrotoxic phase, right? In the thyrotoxic phase, we generally recommend, and this is based on NCCN guidelines, ASCO guidelines, the recommendation is to monitor these patients for clinical findings or clinical symptoms. And about a third of these patients are symptomatic. Two-thirds of these patients are barely symptomatic despite having abnormal TFTs. So when you see that one-third population or 30% of the patients who also have abnormal labs and have symptoms, the most common symptom that you see is palpitations. And what you want to do when you encounter a patient during the thyrotoxic phase or when the patient is hyperthyroid, you want to monitor them for these symptoms and only treat them symptomatically. For example, if the patient has a high heart rate, has palpitations, you want to treat them with a beta blocker. If they have painful thyroiditis, you want to give them an NSAID. Oftentimes, patients always present with painless thyroiditis. I can count on my fingers the number of patients who have actually developed painful thyroiditis with this. A majority of cases always develop this as painless thyroiditis. And once you've bridged that phase, which is the thyrotoxic phase, and the patients move into the hypothyroid phase, considering their age and cardiac status, you would want to replace them with thyroid hormone replacement. And the dose can range anywhere between 1 to 1.6 micrograms per kilogram. There was a study that was done that showed that patients who develop immune checkpoint related hypothyroidism require a slightly lower dose, up to 1.4 micrograms per kilograms, compared to patients who had surgically removed thyroid glands. So that gives a range of what you would want to do with these patients.
Great. So I know for a lot of other toxicities that you kind of do gradations of severity, right? So for thyroid, do we grade them as mild, moderate, and severe on a grading scale? And then do you stop the immunotherapy, or we just treat through the thyroid side effects?
Great question. Now, there is a CTCAE grading that oncologists follow. There is none within the thyroidology world or within the endocrinology world, but this is a pretty standard thing that most oncologists follow and collect information on patients who develop adverse events. And they range from 1 to 5. 1 is just basic abnormalities in thyroid function tests. 2 is mild symptoms with abnormal testing. And 3 is clinical symptoms that require treatment. And 4 is life-threatening, and 5 is death from a adverse event. And this is standard across all toxicities that patients develop. So they have a grading system that they actually monitor patients with. Now, the second question that you asked with regards to what we would do with regards to cancer treatment, we never recommend that patients be stopped with their treatment, because the way we envision this and the way we see this is that the thyroid gland is obliterated. And even if you continue to give them immune checkpoint inhibitors, that thyroid gland is not salvageable. So there's no reason to hold off on treating patients with continued treatment with immune checkpoint inhibitors. Now, is there a risk for patients to develop type 1 diabetes or other autoimmune or immune-related adverse events? Absolutely. But that should not stop the oncologist from continuing to treat someone with a life-saving medication.
Okay. So I actually wanted to transition a little bit to patients from here. Um, Now, if patients do get these side effects, how do they impact like quality of life and well-being for these patients? Are there any studies on that?
Yeah, I think this is really important, especially from a patient perspective, right? And I think it's an important aspect that really merits more attention. Over the last decade, I've cared for numerous patients facing this issue. And from my experience, managing checkpoint related thyroiditis is relatively more straightforward than, say, type 1 diabetes or immune hypophysitis. But that's, again, a clinician's perspective, right? Patients experience and sense things very differently. But during the visits and before the patients come to see me, they often express a lot of anxiety about their diagnosis, its implication for their cancer treatment, and overall well being. What I've found is that sitting down with them and addressing these specific concerns can greatly alleviate their worries. I often reassure them that this condition is quite common, easily treatable with thyroid replacement, and does not interfere with their ongoing cancer treatment. I emphasize that our care will extend far beyond their cancer treatment period, providing ongoing support and management throughout this course. And I think by outlining a clear management plan and addressing their questions and concerns, patients generally feel reassured about their current and future plans. And this approach really helps them understand what the path forward is. The only place that I really see or observe that patients have a difficulty with quality of life is anecdotally, I've seen that patients who receive ongoing treatment with checkpoint inhibitors require multiple dose adjustments for their thyroid replacement. And I often joke with my patients that when I have to change their thyroid replacement dosing or levothyroxine multiple times, that it doesn't mean I don't know what I'm doing. It's just the nature of what you got going on. And this need for adjustments really may stem from the ongoing impact of the checkpoint inhibition or the immune-mediated activation of the immune system on the thyroid gland. And it really takes some time for optimal dosage to be determined. So these fluctuating thyroid labs can really impact the quality of life in these patients, amplifying symptoms typically seen in the general population, right? And remember, these patients, you have to see them from a context of cancer treatment. They can have additive effects to their cancer treatments itself and other complications they may be going through, right? They may have neuropathy in addition. They may have colitis in addition. They may be losing weight because of just generally from their chemotherapy with immunotherapy treatments. So you really have to take an approach which is a whole person approach when you're trying to derive and understand the impact of the thyroid on their quality of life.
And speaking of that, is the thyroid-related side effects, are they more common than some of the other side effects that you discussed compared to type 1 diabetes or, colitis, weight loss, neuropathy? How do you compare the thyroid versus a non-thyroid side effects?
So when we look at the thyroid versus non-thyroid side effects, right, thyroiditis or thyroid-related toxicities really take one of the top three positions, depending on which trial you pick up, right? Um, and it's followed closely by colitis with pneumonitis, and in some studies, hepatitis as well. And skin toxicities seem to be quite common. So I would put thyroid toxicities among the top three contenders for the most common toxicities that are noted in these patients. And when a pharma company or a drug company or the guidelines actually say that you have to test someone's thyroid labs every 3 weeks, it tells you that it is, number one, very common. And number two, it is something that you can treat easily and move on. And they want you to monitor it very closely.
So, what advice do you have for healthcare professionals who are treating patients with these kind of medications?
I think the advice is different for oncologists and endocrinologists, right? When it is an oncologist treating these patients, certainly my common advice is to make sure that you are interpreting fatigue in the context of thyroid labs and other labs, especially within the endocrine system. And it's important to not ignore symptoms, especially when patients have abnormal thyroid labs, and testing them frequently, which they already tend to do, but also testing them post-treatment. Because what often happens in the oncology world is that when patients are on active therapy, they get labs done every 3 to 6 weeks. But once the treatment is complete and they are in the surveillance phase, the immune system continues to be ramped up, and it can still cause thyroid toxicities beyond the ending of the cancer treatment or beyond the last infusion. And what I often tend to see is that patients get dropped with regards to monitoring their thyroid function tests after treatment completion. Now, that's the perspective for oncologists. For endocrinologists, the common advice that I give is make sure that you are interpreting the thyrotoxic phase correctly. And if there is a doubt that the patient has the more rare thyroid abnormality, which is Graves' disease, make sure you're confirming that before you put patients on methimazole. Because that's one thing that I've seen as a common thing. I'll encounter a case or two every month or other month regarding a patient who truly has thyroiditis, but presented with a completely suppressed TSH and a very high free T4. And it scared the clinician who's taking care of the patient because they're concerned with Graves' disease. And they put them on methimazole without confirming that the patient had Graves' disease. They should be getting thyrotropin receptor antibodies, thyroid stimulating immunoglobulins to confirm this before they put them on methimazole. And they still have a clinical suspicion for Graves' disease. Despite negative antibodies, they should consider doing an uptake and scan, obviously taking into consideration when the patient received their last iodinated contrast, which is hard to find in the oncology patient population because they get so many imaging studies done and fairly frequently. So be careful when you're putting patients on methimazole. Be sure that you're treating the right disease. What happens if someone with thyroiditis gets on methimazole is that when they transition to being hypothyroid, which they will, no matter what you do, it's hard to figure out is it the methimazole that's causing it, or is it because the patient just transitioned to being hypothyroid? And you have to stop methimazole for a couple weeks in order to figure out where that trends out. So in order to avoid this diagnostic dilemma and treatment dilemma, it's always wise to get the antibody testing or the confirmatory testing for Graves' disease before considering methimazole.
Thank you. Thank you for providing both perspectives, of the oncology perspective and the endocrinology perspective. Do you recommend that all these patients, if they have confirmed abnormal TFTs, that they come see endocrinology, or is this something that oncology can manage and only few patients have to come see endocrinology?
I think that's a great question. And it really depends on when you asked me this question, right? Because 10 years ago, when I started doing this, I was seeing every patient with a normal thyroid function test, right? It almost became that like the troponins for cardiologists, right? And now, as oncologists have become more and more comfortable managing thyroid disease, putting patients on levothyroxine, the common things that need an endocrinologist to weigh in, or the common referrals that I now tend to get, are the ones where the oncologist requires frequent dose adjustment, which is kind of what I was talking to you about earlier, that it's more anecdotal, where I tend to see patients requiring frequent dose adjustments. Those are the kind of patients that end up coming to endocrinology and should come to endocrinology. The other ones are patients who have, say, colitis or any other thing that's going on that affects their absorption. And it requires a more fine-tuning and a more refined approach to managing hypothyroidism or thyrotoxicosis in these patients. Those patients should come to see us. And then patients who have persistent thyrotoxicosis or hyperthyroidism beyond the 6 to 8 week mark should see an endocrinologist, exactly for the reason that I've told you, is to identify if this is Graves' disease versus thyroiditis and the thyrotoxic phase that is just more extensive. Even though the median time is about 5 weeks for resolution, it can range sometimes up to 20 weeks. So you really want to make sure that you're treating the right animal when it comes to the thyrotoxicity.
And speaking of that, since these medications have now been out for over a decade and we've seen some of the side effects, and oncologists and endocrinologists are much more comfortable managing them, what would you say is kind of where future research is headed on for these side effects related to the thyroid? Is there any more research being done? And what studies can be done to kind of help us manage this?
Yeah, I think that's a great question. And if you ask me, there's certainly a lot of, studies that need to be done in this space, right? We want to identify who's at risk. We want to identify if we can change the course of this disease. If you ask me as a human being, if I want to avoid taking medication for the rest of my life, I'd say absolutely, right? And that's the way patients feel. Even though it seems not like a lot to do, which is take a pill first thing in the morning every single day, if you had to take this for the rest of your life, it can certainly catch up with you. So there is a lot to be desired regarding understanding what thyroiditis is, what the pathophysiology is, why is it so different from traditional thyroiditis, which can take weeks to months to move from hyper to hypothyroidism. These patients move very quickly. Is there something we can do to intervene, right? So there was one study that was published by Dr. Lechner and her team, published in Science from UCLA in mid-2023, that really sheds light into the mechanistic, pathways about this, or the mechanistic basis of this. And the study really compared phenotypes of thyroid infiltrative cells from individuals with checkpoint-induced thyroid disease, patients with regular Hashimoto's disease, and individuals with normal thyroid glands. Now, in their findings, checkpoint-induced thyroiditis was really characterized by IL-21 producing T follicular helper cells and T peripheral helper cells as well. And that was the one that was found to drive the expansion and cytotoxic activity of thyroid infiltrating effector CD8 plus T cells. Now, similar populations of cells were observed in a mouse model for ICI thyroiditis, really suggesting that there's a translational relevance. Perhaps there's a relevance in of this even in general thyroiditis. We don't know yet. But I think there's further studies that are warranted to validate these findings and establish the efficacy of any therapeutic intervention that is developed around this.
Thank you. So this has actually been very educational. I was wondering if you could provide like 3 main points for our listeners today that they can kind of take away from the thyroid-related side effects of these medications.
Absolutely. I think keeping a low threshold to identifying and treating patients, and folding your hands really when the patient is in the thyrotoxic phase. You'd really want to do, sometimes doing less is more. And oftentimes you're causing more harm to patients when we try to fix things with methimazole So folding your hands and watching through that course sometimes is more important than actually jumping in and doing something. And for folks who are interested in endo-oncology or oncoendocrinology, which is kind of focused on endocrine disease and cancer, what I would suggest as an endocrinologist to reach out to your oncology colleagues and identify what their needs are, and understand how you can help them in these cases, because really they need some help, and we're there to help. And it's really nice to have a very collaborative, multidisciplinary approach to managing these conditions.
Thank you. And thank you for joining us today on this podcast.
Well, my pleasure to be here. Thank you so much for inviting me.